some point. All right, so continuing on our theme of glands, we're gonna do salivary gland. And so today will be the didactic, and then Thursday will be the unknowns. And I have them already, so again, I'll just send them out to you in Path Presenter, like right after this. If for some reason I forget, just text me and I'll send them out, but they'll come to you now. Okay. Salivary gland. So we'll talk about normal histology. There are a few, not many, non-neoplastic entities, and most people talk about the neoplasms. So for the major glands, we're dealing with three, right? Parotid, submandibular, and sublingual. And depending on the morphology of the acini, you can sort of know where you are, right? So if you remember, parotid is serous, submandibular is mixed seromucinous, sublingual is usually generally predominantly mucinous. And then there are minor salivary glands all over the entire upper aerodigestive tract. So the palate, the trachea, bronchial tree, the entire sort of tongue and mucosal area, right? So you can get salivary gland tumors in pretty much any anatomic site where you have a minor salivary gland unit. And so the entire sort of upper aerodigestive tract and even sort of the lower lung area. As a reminder, the serous acini have zymogen granules in them, which contain the sort of digestive enzyme precursors, right, that get excreted and then activated by cleavage. The mucinous have essentially entirely mucin, which serves for lubrication. And then you can see how the mixed ones have sort of half serous, half mucinous. You may hear the word in your histology textbooks, you may hear the word demilune, right? So sort of half moon or part moon, because of the way that these acini have these mixed shapes. Okay. So non-neoplastic begins. So one of the more common things that you'll see in the oral cavity might be a mucocele. And so this is basically a pseudocystic reaction to extravasated mucus, in which you have these pools of mucin, and at the edge is just sort of fibrous tissue and these macrophages. The macrophages have ingested the mucin, so we call them mucophages. Often they're in areas of biting, so like lip, tongue. You can get them in the floor of mouth, in which if they bulge like this, they can be called a ranula, in sort of reference to this sort of bulging gullet of the frog. This ranula can plunge from the sublingual space down in through the sort of mylohyoid muscles, etc., into the neck, and so therefore that might be called a plunging ranula. And clinically, this is usually quite known. So you'll definitely see mucoceles on your service. Stones you may not see, but they often treat them with like lithotripsy. Occasionally you'll get a stone for growth only, and very, very occasionally you'll actually have a stone that's small enough that you might be able to sort of decalcify and cut through in tissue. And you can see that they are present within ducts. There's a nice ductal epithelial lining here. Generally, some kind of material serves as a nidus, in which the stone and the calcified material kind of forms around. If the patient comes with mealtime-like symptoms, that could be a stone, right? Because if you imagine that at the mealtime is when the saliva is trying to come out and it can't because it's blocked by a stone. We definitely see these lip biopsies for Sjogren's syndrome, which, you know, I don't know that they're extremely helpful. Sometimes they're present. They take them in patients where the clinical picture or the serology is like equivalent or ambivalent. And so sometimes the histology is also ambivalent. But what you're looking for is basically a focus of at least 50 or more lymphocytes. And you have to score it, not in the entire tissue, right? Because you might get this amount of tissue and you might get this amount of tissue. You just have to score essentially the most inflamed, about 10x objective field. And if you have one focus of 50 or more lymphocytes, that's essentially predictive of Sjogren's syndrome. So we give them a focus score. They're looking for these words. They're looking for a focus score of whatever. So if you say, oh, there are a few plasma cells here and there, but nothing focus score 0, or there is a good focus score 1, et cetera, et cetera. And so that might look like this. where you actually have a discrete clump of lymphocytes, in which you're able to say, yes, this is a focus score of 1 and a quote unquote grade of 3, but the focus score is usually more important. Okay, so that's Sjogren's. Other salivary changes that we see, especially in this hospital where we give a lot of chemoradiation for other like head and neck cancers, right? Oral cavity or pharynx, whatever, you can see a lot of atrophic changes in the salivary glands. And so in this case, you see replacement of the background stroma essentially by fat and fibrosis and kind of this shrinkage or like shriveling of the acinar units, right? So they're not as plump or as juicy as we might see in the regular glands. There's also a lot of inflammation in the background. But what you notice on low power, if you have enough tissue, right, is that the ductal lobular architecture is preserved. So you still have these central sort of open lumina ducts and then these branching acini that come out of the periphery. And so you talk a lot about the sort of these ductal lobular units in breast, right? But this is the same. It's the same concept of these peripheral kind of grape-like structures attached to the central duct. That might help you out when you are possibly that structure when you're dealing with sialometaplasia. Sialometaplasia being squamous metaplasia of salivary tissue. And so you can have squamous metaplasia in the acini, which are very small. You can have squamous metaplasia in the ducts, which are much larger. And often, again, this is in the context of some kind of prior radiation for head and neck cancer. There are these severe forms of sialometaplasia that appears these ulcerated lesions on the palate, but more often what we are dealing with is just microscopic sialometaplasia in the oral cavity and other areas. And so you sometimes will see like residual mucocytes, which is a good hint. You sometimes see preservation of the lumina of the duct with this like grungy material in the middle. And if you have enough tissue, again, you'll see that lobular architecture being preserved. Unlike squamous cell carcinoma, right, which is the mimic of this, or this is a mimic of that, you usually have pretty rounded nests because these are still within the confines of the acini, rather than these highly angulated, infiltrated, very pleomorphic looking squamous nests. So this can be tough, especially on a frozen, if you're dealing with a treated case, but always look for, I can't reach up there, always look for the residual, right, the residual acini, see them, the residual mucus cells or the residual ductal lumina. All right, moving into are they tumors, are they not tumors? So there's this entity called sclerosing polycystic adenosis, which is now being changed to sclerosing polycystic adenoma. This is a very rare lesion that almost resembles kind of like a robust, very prominent kind of fibrocystic lesion of breast, where you have these tumor nodules of either very cystic areas or very solid areas composed of these kind of acinar units. This used to be thought to be a kind of reactive or hyperplastic disease, but recently this kind of series of mutations has been found. So just keep your eye out for sclerosing polycystic adenoma, but it's probably one of the rare salivary type of neoplasms. The more common neoplasms we'll get into now. So questions before we get into those? Yeah, okay. Generally, just like we talked about in soft tissue, right? More commonly, you're going to be dealing with a benign thing. In the salivary glands, it's mostly going to be your pleomorphic adenoma as your most common tumor of salivary gland and your most common benign tumor of salivary gland, of course. You're mostly going to be dealing with things in the parotid, but you certainly could be dealing with salivary tumors in any anatomic site that has salivary tissue, which we already talked about. Interestingly, if you're dealing with a sublingual gland, that area has the highest rate of malignancy. So always sort of keep your, spider senses out once you're in the sublingual gland. Epidemiologically, we already said PA is the most common, followed by Wharton, and we'll look at all of these. Mucoep is the most common malignant, followed by adenoid cystic. One thing to note, especially about salivary tumors and mucoeps specifically, they can be present in children, right? So we don't normally think about kids as having many carcinomas. Well, mucoep of salivary gland certainly, and then papillary thyroid, et cetera, it certainly can happen in kids, right? So glandular cancers can happen in kids. Pretty low rate of all head and neck cancers when you think about salivary. More commonly, right, we're dealing with squamous cell carcinomas of the mucosal sites, and certainly thyroid, if that's being lumped in. So just like other anatomic sites that are amenable to superficial biopsy, FNA is preferred screening for salivary. Occasionally, core. And core for salivary is pretty good because you can do immunostains. So unlike thyroid, where we don't like core because it like destroys your nuclear features, core for salivary works generally pretty well. And we try to follow kind of a way of thinking about how to diagnose these salivary neoplasms, whether it be on FNA or core. There is a Milan system for salivary cytology, and those of you who are on cyto may have talked about this, ranging from non-diagnostic to atypical to definitely neoplastic to, but I don't know if it's malignant, right, to definitely malignant. And honestly, this is less helpful for the clinical teams than the scenario I'm going to give you on the next slide. Any salivary neoplasm will generally undergo surgical resection, with the exception of a few that may occur in like older people and don't really have the potential to transform. Like a Wharton tumor, for example, is one that they may choose not to resect because it can stay in the patient and do nothing. Unlike pleomorphic adenoma, which does have a possibility to transform to malignancy, so they will take those out. What they really do want to know, though, rather than is this benign or malignant, they really want to know, is this, oh, it's coming. Is this high grade or not high grade? So rather than benign or malignant, grade is more important. You can have a low grade malignant and a benign neoplasm in which the treatment is going to be the same, which is resection with clean margins, versus a high grade malignant in which they're going to probably also do a neck dissection. There are some diagnoses on FNA that are obvious in terms of what is the exact diagnosis. You know, we have sort of these generic, non-specific things like chronic inflammation, normal acini, right, which kind of look like grapes, cyst contents, and then we have actual diagnoses that are doable, makeable on FNA. Diagnoses that are generally makeable on FNA include things like pleomorphic adenoma, sometimes adenoid cystic with those big gumballs, Wharton tumor with oncocytes and lymphocytes in the background, and sometimes mucoep with these little mucinous cells, right? So sometimes you're able to give a very specific diagnosis on the smear or the core, but sometimes you cannot because the morphologic features are overlapping. And when you cannot, you want to get across the grade. Is it a low grade or is it a high grade? Lots of mitoses, necrosis, pleomorphism, all the things we think about with grade, right? Because if it's a PA or a low grade, you know, or a low grade mucoep, it's probably going to be resected and treated the same way up front surgically, okay? The difference is if you're dealing on biopsy with a so-called basaloid neoplasm, meaning it's very cellular, it's very blue, there's some stroma, but you can't really tell whether that's like pleomorphic, do they still call it troll hair, pleomorphic adenoma troll hair stroma, right? Or the adenoid cystic gumball stroma, or there's a mixture. Because then, why we care is because adenoid cystic is generally considered much more aggressive, both sort of locally and local regionally. And so they may do wider margins on an adenoid cystic, and they may do a sort of preemptive neck dissection on an adenoid cystic. This is all, of course, implying that there is no overt metastatic disease, right? If there's obvious overt neck metastatic disease, we're dealing with a high-grade tumor, fine. But if there's not overt neck disease, they may end up doing a neck dissection with adenoid cystic, whereas with a basal cell adenoma or basal cell adenocarcinoma or pleomorphic adenoma, they would not. And we'll talk about the morphology of all these, don't worry. But so now what we have done here, we've come to this agreement where if you have a basaloid neoplasm, we will do the RNA fusion to probe for the typical fusions of adenoid cystic, which are what? MIB NFIB or MIB L1 NFIB, exactly. So if it comes up with that fusion, it's an adenoid cystic. We've had examples here, so if you're on Cyto, ask, but we've had examples of a basaloid neoplasm come out with a PLAG mutation, a PLAG fusion, and we've had them come out with a MIB fusion. And so the morphology can be very, very, very challenging, and that's why the genetics is more important. The other thing to remember is that in the parotid and submandibular region especially, you can have intra and periglandular lymph nodes, right? And those lymph nodes can, number one, mingle with normal salivary tissue, so you can get tumors arising adjacent and essentially in salivary gland lymph nodes, but you can also get metastatic cancers to those nodes, especially those that drain the skin. So generally, if you're dealing with you want a parotid or submandibular, you also want to think about this. Could this be a met? Could this be a metastatic melanoma or metastatic squamous cell carcinoma from the scalp or sort of surrounding regions? Because that's the first site that it drains. Okay. So once the patient comes to the operating table, we of course are going to confirm whether this is truly a primary or a metastasis, whether this is low or high grade, how are the margins, and then of course, what is the TNM stage? The one benign tumor that we always comment on with margins is pleomorphic adenoma, right? Because this has a high propensity to recur and a high propensity to transform to malignancy. This is everything tumor-wise. So for those of you who like charts, it's here for you. Kind of on the left, what's the benign tumor? On the right, is there a malignant counterpart, right? So some benign tumors have sort of malignant counterparts, some do not, and some malignancies have no benign counterparts. So I kind of like to think of it in that way because these are all the things that are going to go through your head. How many cell types are there? So you can see up here are the tumors that are biphasic, that have epithelial and myoepithelial cell component. The tumors here that are essentially monophasic or monomorphic. And then the sort of rare exception being mucoep, which is thought to be kind of 3 cell types, mucus, intermediate, and squamous. And we'll see all of these morphologies. Now we know that many of these salivary neoplasms have tumor-defining genetics. So in the past, we had pleomorphic adenoma and monomorphic adenoma. Because they all, I don't know, it either had 2 cell types or 1. That's what it was like historically. Now, we have all these different subtypes of monomorphic adenomas, and we know based on what the morphology and what the genetics are, what they might be. Okay, if you want sort of morphologic impressions, you can combine whether it's sort of biphasic or monophasic with, is it monophasic myoepithelial, is it monophasic epithelial, and then what is the underlying morphology? Very sort of solid, more kind of secretory or cystic, more of that basaloid cribiform. So you can sort of sort things based on a number of factors into these sort of patterns of thought, right? And so I can give you guys, this is published in one of the papers I wrote with one of our former fellows in terms of how do you approach this differential diagnosis and what immunostains might be helpful to sort it out. So remind me, I'll link you guys to this article if you want to read our differential diagnosis sort of breakdown. In general, how do we want to start? We want to look at the border, right? Is this a circumscribed thing or an overtly infiltrative thing? If it's overtly infiltrative, it's going to be malignant. However, if it's circumscribed, it could still be a low-grade malignancy because some low-grade cancers still have a circumscribed border. We always want to think about the number of cell types, epithelial, myoepithelial, and is it monomorphic or biphasic? And then we can go into these morphologic pattern groups, which might help sort the monomorphic biphasic plus the morphologic pattern group might help us. But H&E with select use of immunos and select use of genetic testing. So we're going to start diving into each of these individual tumors. Questions? All right, starting with the most common one, which is of course PA. And when you look at these on gross exam, it very well might, if it's a very chondroid stromal rich, it might just look like cartilage to you, which is expected because a lot of the stroma in PA is chondroid. There may or may not actually be a capsule, but the border should be very kind of circumscribed. We don't think of pleomorphic adenoma in terms of cellular or cytologic pleomorphism, but in terms of architectural heterogeneity or architectural polymorphism, because there can be a wide variety of morphologies and architectures that PA can take on. The commonality is they have to have both epithelial and myoepithelial cells in them. And they generally, but not always, have some kind of myxoid to mixochondroid to frankly cartilaginous matrix. And so the biphasic pattern that you'll see, and you want to look for these in your salivary neoplasms, is these bilayered ducts, right? So when I say biphasic, that's what I mean. I mean, this looks like a normal duct, but this is within the context of a tumor, and both of these cell types are neoplastic. Both are neoplastic. So you have the inner epithelial cell layer and the outer myoepithelial cell layer, and then in the background you have this chondroid chondromyxoid stroma. These guys are generally thought to be myoepithelial cell phenotype, the ones that are single cell in the background stroma. Sometimes those background myoepithelial cells can be very prominent and very cellular, and so they can range from these kind of what we saw earlier, kind of inconspicuous ones, to these very, very densely cellular populations of plasmacytoid. Some people call these hyaline epithelial cells because the cytoplasm has this like glassy hyaline globule in it, or extremely spindled, almost looking like a mesenchymal neoplasm. And so they can have varying morphologies, varying like percentages in the tumor, and even varying immunophenotypes. So when we will talk in a minute about the phenotype of myoepithelial cells, just remember that it's not always uniform. Okay. The other unique thing that you may see in the stroma of PAs are tyrosine crystals. They basically don't happen in other salivary neoplasms, so that can be helpful if you see it. And just to remember that your chondroid stroma of a PA can look very, very, very much like cartilage. So what can PA do? It can recur significantly right after incomplete excision, and it presents as these sort of multiple nodules kind of percolating through the residual tissue. Some people think that it can metastasize in a morphologically benign manner, but I don't know. This is controversial. This might not actually be a PA. This might have been some other low-grade salivary carcinoma. So maybe question mark on that one. It can certainly transform to a high-grade carcinoma X. Of generally, it can resemble any salivary type of carcinoma, it's thought. The common ones are salivary duct, which we'll see, or sort of a generic like bad carcinoma NOS, but usually this is high grade. Okay. So what does this look like? So recurrent pleomorphic adenomas are these multiple small lobules in the stroma. So I've heard, I shouldn't say this because it's probably verboten, but people have said that this has come up on boards where like they'll give you like something that looks like a pleomorphic adenoma, but it's like tiny, tiny, tiny little drops in the stroma. That is recurrence. There is no way that that is not recurrence. Primary pleomorphic adenomas can have sort of tongues that project into the like neighboring stroma, but there's generally a dominant mass with little like what they call sometimes like little pseudopods. If it's like little buckshot nodules in the stroma, that's recurrence. Malignant transformation, by definition, you either have to see a malignancy with evidence of an adjacent benign adenoma, and sometimes the adenoma can kind of regress or scar down, and all you get is this like hyalinized nodule, and then all this malignant tumor around it. That's carcinoma X. Or you had a prior benign pleomorphic adenoma, and then you have a recurrence as a malignancy. It's thought to start, especially the salivary duct carcinoma X's, are thought to start within the ductal system of the PA, right? So remember we saw those bilayered ducts. You can see that the outer layer is a myoepithelial cell layer, and it stains with P63, P40, and the inner layer is negative. It is in those inner layer cells that start to develop nuclear atypia, pleomorphism, mitoses, whatever. They get some kind of additional genetic like hit, right? And they start to transform, mitoses. If it's resected in this manner before it is invaded out, the prognosis is extremely, extremely well. However, once you have invasion out of the pre-existing PA into the adjacent tissue, that's when you get metastases and mortality. You can see here this pre-existing, basically overtly hyalinized pleomorphic adenoma in the background. Again, with your invasive carcinoma out here, this happens to be a myoepithelial carcinoma, ex-pleomorphic adenoma. Okay, genetically, the initial hit for PAs are PLAG gene rearrangements. There's this new kind of variant of pleomorphic adenoma that is morphologically slightly diverse and high level. We can talk about that on service when you come to us. But there are these HMGA2 expressing tumors as well. So PLAG1 and HMGA2 are the most common genes. Malignant transformation, second hit, you're probably going to get something like a P53 or some other high grade mutation that will push it into high grade transformation. Okay? Okay. Sorry, we took a long time on PA because that's the most common thing you're going to see. And I want you to understand it well. What about if you are dealing with a benign appearing salivary neoplasm that does not have any overt epithelial cells? If it's circumscribed and it's purely myoepithelial, being sort of either clear cell or epithelioid or spindled or again that plasmacytoid, well, I don't know that this actually exists, because if you look hard enough in a myoepithelial rich tumor, you will generally find neoplastic ducts, in which case you can call it a pleomorphic adenoma. Most truly myoepithelial pure tumors are actually malignant, right? So if you're dealing with a truly myoepithelial pure tumor, think about either it's a PA in disguise or it's really a myoepithelial carcinoma. Back to your immunophenotype of myoepithelial cells. So neoplastic myoepithelial cells, whether you're dealing with a salivary, or we even talked about myoepithelial tissue, tumors in the soft tissue and bone, right? Phenotype persists, being you have to have some kind of keratin or epithelial membrane antigen, and something in the myoep specific bucket, whether it be a contractile marker, right, like an SMA or a calponin, or a sort of basaloid marker like a P63, P40, or a neural crest marker like an S100 SOX10 GFAP, right? So you have to have one of these and one of these, and you can't always know what that myoepithelial cell population is expressing. So we generally perform a panel of basaloid markers, a panel of neural crest markers, and a panel of contractile markers, okay? Because you never know which it's going to express. Myoepithelial carcinoma, as we said, can be de novo, and as I showed you in that one example, can transform from a pleomorphic adenoma. If these are de novo, they often can have EWSR gene rearrangements. If they're transformed, they'll retain that PLAG gene rearrangement. The low power morphology of a myoepithelial carcinoma is usually very predictable and discrete. And so it's these sort of cloud-like nodules of tumor, often with central kind of degeneration or central necrosis or central sort of stroma with cellularity at the periphery. And in the periphery, you're going to see these sort of nests and cords of epithelioid cells, often within a very mucinous stroma. Remember, myoepithelial cells secrete connective tissue or stromal mucin, not epithelial mucin like we'll see in mucoep, right? You're not going to see goblet cells, but you're going to see stromal mucin. And so this is very characteristic of myoepithelial carcinoma. As we will see later, but I'm going to say it now, epithelial myoepithelial carcinoma has a very similar low power appearance with these cloud-like globules. The difference is in the cellular components, you'll see both epithelial and myoepithelial cells. And I'll show you that later, don't worry. So that's myoepithelial. Questions? All right. Warthin tumor is your next most common benign tumor. Some people don't even think it's neoplastic because no one's ever really been able to prove clonality in these. They often happen multifocally or bilaterally, especially in the context of smoking. So maybe this is an oncocytic reactive proliferation to injury from smoking, but we call it Warthin tumor for what it's worth. They often have this grungy secretion with these large cysts and solid areas. The grungy material is whatever is secreted by the oncocytic cell layer, and so you should expect in a Warthin tumor to see these nests lined by 2 layers of oncocytes and then a background lymphoid stroma. These often get picked up on PET scans because what do smokers get? They get lung cancer, they get bladder cancer, they get other kind of cancers, they get oral cancers, right? They get a PET scan and then something pops up and they're parotid. Guess what? It's a Warthin. So don't be surprised if that happens. You will generally see something that almost on low power is going to look like a lymph node, but really it's in the context of these dilated glands lined by this oncocytic epithelium. So really in these tumors, there's not generally any risk of malignant transformation, again, because they're probably not even neoplastic to begin with. As you all know, right, oncocytes are just cells rich in mitochondria, so there's electron micrograph of all the mitochondria. Maybe that's what accounts for the PET avidity. So what is PET, right? PET is fluorodeoxyglucose. It's glucose, right? So what do your mitochondria do? They take glucose and put it through the citric acid cycle, right? So perhaps because of all the active lymphocytes and all the active oncocytes that are taking up this glucose, maybe that's why these are PET avid. Okay, there are pure oncocytomas that are not Warthin tumors that have 0 lymphoid stroma. These are generally in older patients in the context of so-called nodular oncocytic hyperplasia or oncocytosis. Somehow in people's 70s, 80s, the salivary tissue starts to develop these little nodules of oncocytic metaplasia in the background, reactive change, whatever, toxins. And then some of these oncocytic nodules can maybe have a neoplastic transformation or just grow to a large size, in which case they become a dominant nodule, right? And they can now be referred to as an oncocytoma. As you can see, it's solid, essentially solid and trabeculated oncocytes without any lymphoid stroma. And in any oncocytic neoplasm in any site of the body, you can have essentially voiding of the cytoplasm, in which case it might appear cytoplasmically or optically clear. So you can have clear cell oncocytic things, which is a little bit of a oxymoron, but whatever, it's fine. So oncocytoma can exist as a benign neoplasm in the context especially of oncocytic hyperplasia. Okay. Is there an oncocytic carcinoma, then you may ask? Well, this is controversial and I didn't put it on here for that reason, because it is thought that if you have a carcinoma that has predominantly oncocytic morphology, you may be dealing with an oncocytic variant of some other tumor, like an oncocytic mucoep or an oncocytic salivary duct. So it's probably not a pure malignancy anymore. It's probably a morphologic variant of some other malignancy. Basal cell adenoma is one of those where you can have a basal cell adenoma and a basal cell adenocarcinoma. Now, this is not basal cell carcinoma of the skin, right? This is basal cell adenocarcinoma of gland. The benign counterpart, basal cell adenoma, is another one of those that is biphasic, having epithelial and myoepithelial cells with more basement membrane or eosinophilic stroma rather than the myxoid blue stroma. They have either one of 2 mutations, beta-catenin or the CYLD standing for cylindroma. So does anybody know what this Brooks-Spiegler or cylindroma syndrome is? Yes, it's these turban tumors where these people get these big cylindromas on their heads. Cylindromas being a dermal tumor, right? This is the same mutation that can happen, and you'll see it. You'll see maybe a little bit of similar morphology to cylindromas. Okay, basal cell adenoma, by definition, because it's benign, should have a circumscribed border. It's very blue on low power, so you can see how it enters into the basaloid differential diagnosis on biopsy. You can see that it's composed of these nests of almost kind of these rounded pieces that fit together like jigsaw puzzles, so sometimes this is referred to as a sort of a jigsaw puzzle morphology. If you go on higher power in these nests, they often have peripheral palisading, and you will often be able to see this hyalinized globular basement membrane eosinophilic stroma, either as these globules or as bands around the nests. One thing we don't talk about often, but is becoming sort of important in the diagnosis of basal cell adenoma is two things. Because many of them have beta-catenin mutations, you can use beta-catenin as a marker of this tumor, and often you will see nuclear expression localized to the outer myeloepithelial or basal cell layer in this tumor, and sometimes to the stroma. But not every single nucleus is going to have beta-catenin in it, and that is okay. Because if you are another tumor on the differential diagnosis of this, 0 nuclei are going to have any beta-catenin staining, right? So in this case, you have multiple nuclei, even if it's not 100%. So that's positive. You also have this very vague, sometimes nondescript stroma in the background that is richly S100 positive. So yes, we were talking about this the other day. So there is some thought now that maybe this is actually a triphasic mesenchymal component of this tumor. So we know that there are epithelial cells in the middle. We know that there are myoepithelial cells on the outside, and we now know that there are these S100 positive stromal cells in a basal cell adenoma. Some people projected that could they just be spindled myoepithelial cells? Maybe. Now some people are projecting that this might be an epithelial mesenchymal transition. So whatever that means to you, fine. But this is signature of basal cell adenoma and can be really, really, really helpful, especially on core biopsy. There's your turbine tumor of cylindroma. Why I put this here is because mostly basal cell adenoma carcinomas do not have beta-catenin. They have the cylindroma gene, okay? And so by definition, they have to have invasion to differentiate them from basal cell adenoma, because otherwise they can morphologically look really similar with these intersecting jigsaw puzzle pieces with this hyalinized stroma. But you can see here, there's an infiltrative growth pattern. So we would regard that as a basal cell adenocarcinoma. Otherwise, on high power, they are very similar with these stromal globules with the peripheral palisading. So you need the border and able to determine, but mostly, as you can see, these are low grade, not a lot of mitosis, necrosis, etc. So basal cell adenocarcinoma, usually low grade. There is this tumor called canalicular adenoma, which has a very particular clinical pathologic kind of correlation, generally on the lips of older females. So probably not going to make this diagnosis outside of that context. It has this very kind of discrete stranding where you have these like 2 strands of cells that kind of connect and then break out, almost like a train track or something, that come together at like a hub and then branch out again. The stroma is very myxoid and vascular. They sometimes have expression of S100. They have expression of GFAP at the cyst lining, which has been helpful. But this is pretty rare, but it's in here for you to refer to if you ever think you have a case of it. Okay, so those were the tumors that are either benign only or benign with malignant counterparts. Now we're going to move into the ones that are essentially only malignant. Do you guys have questions so far? Okay. Only malignant, we're sort of again dealing with, is it monophasic, is it biphasic, or is it muco-F, essentially. Muco-F being of 3 cell types, squamoid, intermediate, and mucus, like we already said. It generally has an infiltrative kind of ill-defined border on gross exam. Remember, your normal salivary tissue looks sort of yellow and lobulated and glistening, right, compared to this white, gritty tumor. CRTC1 or CRTC3 mammal 2 are diagnostic of muco-F. So in cases where this might be on your differential, but you don't know, we often turn to mammal mammal fusion, which can be very good in assisting with the diagnosis. So on low power, you may see something solid or you may see something cystic. But in general, even in the solid ones, you often will see some small cystic areas. On higher power, you should see mostly, you're probably going to be seeing the mucinous and the intermediate cell types. Intermediate, I kind of think of as these very bland, very nondescript. They're just kind of floating in the background, but when you see them, they're very characteristic of intermediate cells. They aren't squamoid. They don't have intercellular bridges or dense cytoplasm, but if you see squamoid component, that's fine for mucoep. You have to see, even focally, you have to see mucocytes. Some people scour these tumors trying to find 1 or 2 mucinous cells. Mostly, they're going to be obvious in a true mucoep. You want to make sure that what you are seeing, however, is not glycogen in a squamous lesion. So glycogen digests out with the diastase on the PAS stain. Mucin does not, right? So we can use either the mucicarmine stain or the PAS with diastase, right? Because PAS will stain glycogen and will stain mucin, but will digest out glycogen and will not digest out mucin. So that can be helpful. There are 4 published grading systems for mucoep, some of which are quantitative, some of which are qualitative, but all of which might grade differently. So when we've looked at these grading systems, it's the AFIP system grades lower, the Brandwein system grades relatively higher, and these 2 on the periphery are kind of somewhat in between. And so every one of them has a low and an intermediate and a high grade outcome. The problem is the clinicians don't like intermediate because they don't know whether to just treat it with local excision like a low grade or to treat it with neck dissection like a high grade. So we try to push it into a low or a high when we can. In the Brandwein system, it is thought that those that are graded low and intermediate grade are actually biologically low. So if it's a Brandwein intermediate, I generally just shove it into low. But if you give it a Brandwein high, those probably have more likelihood of actually being biologically aggressive. So I try to use that dichotomy when grading mucoep. I don't use this one because it's artificially low. So I try to stick to Brandwein with that caveat in mind. As you can see here, numerous studies, including ones that we have done here, show that the Brandwein low and intermediate are really biologically very, very similar. Okay. Adenoid cystic, next most common one you're going to see. Can be anywhere. Be in the parotid, can be in the palate, can be in the trachea and the bronchi. Anywhere. It can be in the breast, it can be in the GYN tract, right? This can be anywhere. This has frequent perineural invasion, so often you're going to see nerve pain in these patients. You will have a biphasic phenotype, which we'll see in a second. And as we already talked about earlier, MIB or MIB-L1 NFIB fusion. The characteristic growth patterns are tubular, with just these bilayered tubules, cribiform, with these sieve-like spaces, or solid. You can see PNI there on the bottom left. When you're looking for the cribiform, there's tubular, there's cribiform, there's solid. When you're looking for biphasicity, what do we want to do? Generally, the epithelial cells of any biphasic salivary neoplasm will stain for c-KIT or CD117, and the myoepithelial cells of any biphasic neoplasm will stain for P40. P40 being more specific than P63, so we like P40 better. So in pleomorphic adenoma, in adenoid cystic carcinoma, in basal cell adenoma, basal cell adenocarcinoma, right? Those are kind of the 3 common biphasic ones. Always P40 and c-KIT should be on your mind for staining, because if you see this kind of pattern, you have a narrowed your differential into a biphasic tumor. You can see that in adenoid cystic, the cribiform kind of makes like a sandwich, right, with the epithelial cells in the middle. And so the myoepithelial cells secrete that mucin into these spaces, which is why these cribiform spaces have that bluish material, right? So that bluish material is connective tissue mucin because these are actually myoepithelial cells, right? So unlike these tubules in which the center lining cells are just epithelial cells and they're not secreting that. Does that make sense? So you kind of have like an inverted like thing with the cribiform pattern. Okay. We like to give the percent tubular cribiform or solid because that's thought to have some implication for grading. However, mostly what we want to determine is there true high grade transformation? Meaning, has it gone wild? Are there large nuclei, prominent nucleoli, lots of mitoses, diffusely solid architecture? If you looked at this, you would not be able to tell whether this was an adenoid cystic or something else. So you have to look for lower grade morphology areas. The one thing I want to point out is that pretty much any salivary carcinoma that starts off as a low grade carcinoma can undergo high grade transformation or sometimes referred to as dedifferentiation. This is like you look at it, you have no idea what it is anymore, right? So you have to either prove what it is by genetics or by morphology in some other area. One of the morphologic mimics of adenoid cystic is polymorphous. This tends to occur on the palate, although it is not the most common tumor in the palate. More common in the palate is still pleomorphic adenoma and adenoid cystic, but if you're dealing with polymorphous, you may be in the palate. This has a single cell type, so it does not have those P40 cells. It tends to have these oval vesicular nuclei. It can have myxoid stroma though, it could have cribiform growth pattern and mimic adenoid cystic. It can have PNI and mimic adenoid cystic, but what we know about it is it's diffusely strongly S100 SOX10 positive and it's P40 negative. We don't, P63, as I said earlier, is not as specific, so it can aberrantly express P63, but it should not express P40, and it has these PRKD1 gene mutations. So this is what it looks like on low power with this very sort of kind of undulating growth pattern. Sometimes it has these little like whorls or like glomeruloid structures like here. And again, those vesicular nuclei. And you should not see two cell types. And you can prove that by IHC by these being completely negative for P40, unlike adenoid cystic and PA. There is this cribiform variant of polymorphous that is in the WHO, kind of buried under polymorphous, that is thought to occur more commonly outside of the palate, like in the minor salivary glands of the buccal space, the base of tongue. But essentially, it's morphologically similar, it's immunophenotypically identical, and it has PRKD1 gene rearrangements. It is thought, and this is kind of coming to fruition, we'll see if this is true or not, that it may have more frequent lymph node metastases than the original polymorphous variants. But sort of to be determined, but know that this is out there. There's another biphasic tumor that's recently in the WHO called sclerosing microcystic adenocarcinoma. It is its name, it is sclerosing, and it is microcystic or microtubular. It does have biphasic morphology with two cell types and a relatively good prognosis. Pretty rare, but know that it exists. Okay. Acidic is another one that is very overtly evident on low power because it is sheets of purple, right? It's sheets of serous acini without fat, without ducts. So acidic cell carcinoma, if you want, you can do the PAS diastase here to pick up the zymogen granules. If for example, you're dealing with a tumor that's zymogen granule poor, you think it's acidic, but you want to prove it, you can do the PAS diastase. The other thing that this tumor stains for, which I'm not sure I have on this chart, but is DOG1. So sometimes in cytology, we've seen them use DOG1 on a cell block because it will stain it will often stain the apical border of these cells. There are recurrent gene rearrangements in NR4A3 and this other gene MSANTD3. But usually this is provable on morphology. Usually we don't need the genetics for this one because it's so overtly obvious. Unless it undergoes high-grade transformation. in which case it will look like any other high-grade nondescript salivary neoplasm. So again, you're gonna have to use genetics or under background morphology saying, oh, those are serous acini, so that's probably acidic. Do we care so much what the background is? Not really. If you're dealing with a high-grade salivary carcinoma, it is more important to identify that this is a high-grade salivary carcinoma for treatment purposes than what the originating precursor is, right? Because they're going to treat it like a high-grade carcinoma regardless of where it originated from. So that's, if you're in a pickle, focus on the grade. Mitoses, necrosis, pleomorphism, PNI, LVI, all those kind of things. Secretory carcinoma is next, as it was originally very akin to acinic, and it used to be thought of as the microcystic or granule pore variant of acinic cell carcinoma, because it was thought to create these little serous acini, but just didn't have granules. These are not serous acini. This is a completely different tumor, and it was discovered in resemblance to its analog in the breast. This can now happen in any anatomic site. It is defined by EPV6 and TRAC3 gene rearrangements, and it's sort of secretory morphology. So how do the secretions appear? The secretions can appear as these sort of milky or watery or pale pink stuff in the lumen, or these really dense eosinophilic concretions. You can have the cells themselves maintaining some of that secretory material in the lumina, in the cytoplasm. So sometimes you have these cytoplasmic vacuoles if it hasn't kind of gone out yet. But often you'll see this kind of microcystic pattern with this intraluminal watery material. Sometimes you'll see this papillary morphology. But what you will see is diffuse strong expression of S100 and mammoglobin. Mammoglobin generally being a breast marker, right? But in this case, because of its resemblance to breast, it retains that. And negative for, it's not biphasic, right? So you will not see a P40 cell layer here. There are some other tumors in which S100 is diffusely strongly positive. We already saw, mask is written here because this tumor used to be called mammary analog secretory carcinoma, but no longer is that the case. It's just secretory carcinoma. So S100 diffusely strongly positive in secretory carcinoma, polymorphous / cribriform adenocarcinoma. A myoepithelial carcinoma can be strongly S100 positive, right? And then this, there's this other intraductal carcinoma that we'll talk about in a minute. So there are charts at the end of this lecture, kind of going through this immunophenotype. So just hold for that. Just like I sound like a broken record, just like any other salivary gland tumor, this can undergo high-grade transformation, necrosis, mitoses, etc. Okay, microsecretory is yet different. This is also not biphasic, negative for P40, but again also diffusely strongly positive for S100 SOX10. But has this different fusion, this MEF2C SS18 fusion. SS18 you'll remember from synovial sarcoma, right? This is a sort of very, very cystic appearing, microcystic, again, monophasic, very rare. But if you're thinking about secretory, or you're in that differential, also think about microsecretory. Probably doesn't matter where you end up as long as you know that it's low grade versus high grade, and or you want to prove it with genetics. Arguably, the stroma here is more prominent with these kind of intervening fibrous bands between the nests, between the tubules. Whereas secretory is more sort of packed back-to-back cellular without that stroma. All right, salivary duct. This is another one that resembles breast cancer. It's thought to look like DCIS of breast, but this is an invasive carcinoma. This is basically by definition high grade. This has androgen receptor and HER2 positivity, but not ERPR. So if you have diffuse strong ER/PR in a salivary gland tumor, this is a metastasis. It just is. No salivary tumor should have high ER/PR, but it can have high androgen and high HER2. And they can treat this, right? They can treat this with Herceptin, they can treat this with androgen antagonists. So often we are asked to do these immunostains in high-grade salivary carcinomas just as a last straw. Like, can I treat this with any of these? Because if it's positive, they can. You can see how most salivary ducts, again, look like kind of these DCIS-like structures with central necrosis, with these cribiforming, or some people call them Roman bridging on the side. But if you threw a P40 or a P63 on here, more often you would find that it is absent. So this is an invasive growth pattern. It's just very sort of broad-based invasion. You could have different morphologies, micropapillary, solid, apocrine, lots of PNI, so very high-grade salivary duct. Again, de novo or arising out of a pleomorphic adenoma. This newly discovered kind of tumor called intraductal carcinoma is somewhat different in as much as it also has these kind of big gumballs, but there's always a P63, P40 positive myoepithelial or basal cell layer at the periphery. So this is thought to be perhaps within the ductal system of the salivary tissue. You can even see it here on H&E. All right, so if this has a retained layer, it's generally very low grade, cured with excision. We can get into the weeds about intraductal. There are different morphologic subtypes and morphologic variants. But what I want you to know is this is really not considered a low-grade salivary duct carcinoma. This is an entity in and of itself. It has completely different genetics, including RET fusions or BRAF mutations, etc. So just keep that in mind. These are pretty rare, but there is such a thing of intraductal. All right, we're almost done. Another biphasic is epimyoep. Generally, the myoepithelial cells surrounding the ducts in epimyoep are going to be very prominent with a lot of clear cell abundant cytoplasm. And interesting, these have been shown to have HRAS mutations. You can see on the next slide how this very much looks like that myoep that we saw earlier, right? With this central necrosis or central degenerative change, these cloud-like lobules. But when you look in the cellular areas, you'll see, oh, there's a duct, right? So this is epithelial myoepithelial carcinoma. Remember, prominent myoepithelial cells, often with sparse ducts. Sometimes you can have more ducts. That's fine. There could be a varying percentage of ducts of ductal cells to myoepithelial cells, but you have to have both somewhere. And think about HRAS mutation, because that could be helpful if you need it. Hyalinizing clear cell carcinoma is kind of here at the end. It's kind of an odd one. It almost looks like it could be a clear cell myoepithelial cell tumor. It does not have any ducts. It has these wrinkled nuclei, and it can almost sometimes mimic a squamous cell carcinoma, like a glycogenated squamous cell carcinoma, because it's positive for the squamous cell markers, high molecular weight keratin P63, P40, but negative for any of the other markers of myoepithelial cell differentiation, like we saw before, right? No neural crest markers, no contractile markers. So it stains like a squame, right? It stains like a squame, but it has clear cells and EWSR ATF1 gene rearrangement and is generally low grade. So if you don't see a lot of pleomorphism, you don't see a lot of mitoses, but it looks kind of like a glycogenated squame or a clear cell myoep, think about hyalinizing clear cell. And lastly, squamous cell carcinoma of the glands. So probably not existent as a salivary primary. These are probably either metastases from the skin, in which case UV signature will be present, or they can be metastases from the nasopharynx or the oropharynx, in which case you might find EVER or HPV, depending on where you're coming from, or direct extension from like an intramucosal site. So you can get skin cancers of the cheek going into the parotid. You can get mucosal cancers of the mouth going out into the parotid, or you can get metastases from the distant skin to the parotid, right? So we're dealing with a number of ways in which squamous cell carcinomas can get to the parotid. So just think about that. If you see a squam in the parotid, it's probably not primary. As I promised, the summary of your biphasic neoplasms versus your monophasic neoplasms and how they line up immunophenotypically and genetically. So I will leave this for you to peruse. But when you're dealing with an unknown, this can be very helpful to sort of sort it out and what immunos might be helpful to you, because I don't tend to use a lot of immunos in my salivary glands. I tend to use a P40 and a c-Kit, right, for your epithelium and myoepithelium, an S100 because some of them are diffusely strongly positive, and then depending on where else your differential is, you know, you might throw on a couple more. But usually it's c-Kit, P40, and S100 for these reasons. And there is where I will leave you. You guys have questions? Yeah.
Some of the entities that have specific like molecular fusions, like I think secretory,
Yeah.
do you call that without knowing the fusion is there, or do you just suggest that it's like suspicious or secretory molecular fusion?
If the morphology and the immunophenotype is adequate, you can call it. I'm of the belief where, like, if I'm uncomfortable with the diagnosis, I'll generally do the molecular for my first one or first two cases, and I'm like, oh, okay, I get this now. Like, I'm good. I will now call it without the molecular, just based on the morphology, but it's my own comfort level, right? The most important thing, as we said earlier, is can you affirm that it's low grade, right? Because if you're like, this looks like a low grade salivary carcinoma, I think it's secretory, like, probably fine. If the clinical team is like, oh yeah, cool, can you prove it? Fine, go ahead and prove it with the genetics. But for me, it's more of a comfort level thing. Like, until I get to know the morphology, I'll do the genetics and then I'll leave it alone.
And then for polymorphous, I have a question about, is the cell of origin, is it like a bioepithelial?
So we don't really think about cell of origin, but we think about lineage of differentiation. And so there are different immunophenotypes for the different sort of epithelial, myoepithelial, acinar, and then sort of within the ducts. I didn't go through this because it's heavy, but even within the salivary duct system, there are the big, like, excretory ducts, right, where everything shoves out. There are these smaller kind of intercalated ducts and the interlobular ducts. And that's right. So you start as a tiny duct, you get into a bigger duct, and then you get into a giant duct. And so those ducts have different immunophenotypes, some of which have epithelial cells. I think it's the intercalated duct that are actually S100 and SOX10 expressing, even though they are epithelial, even in the epithelial cell component. Okay. So there is some thought that maybe they're intercalated duct phenotype, because you're like, well, it doesn't make sense. Why does it have S100? But is it myoepithelial? Is it not myoepithelial? It doesn't have SMA, right? It doesn't have the contractile component, but it has the neural crest component. So then you get into this, is it one of these weird intercalated duct phenotypes, which might be where that's going, but I felt like that was a little too much for this. But you good question. So I think that's where it is with these. Because if you throw an S100 on or a SOX10 on a normal salivary gland, you'll even see it in the serous acinar cells, right? So there's some non-specificity to the S100 SOX10. Yeah. Okay, I will send out this presentation as a PDF. I will send out the salivary unknowns for Thursday in Path Presenter, and I will send out that article that I was telling you about with the immuno profile. Okay, thank you guys.
Thank you.